All right, so let's learn about thrombocytopenia today. We're going to be going over everything that I listed here, TTP, HUS, etc. Thank you so much, as always, for the support. I really do appreciate it. The comments always make my day, so thank you so much for that. Let's go ahead and get started with thrombocytopenia. So we'll start off with TTP, thrombotic thrombocytopenic purpura. So this is caused by a deficiency in something known as ADAMTS13 protease. So it leads to thrombotic microangiopathy. Because of a deficiency in something known as ADAMTS13, which I'll go over in a minute. Now, the patho behind this, the ADAMTS13 deficiency leads to an increase in something known as von Willebrand factor, which causes this small vessel thrombi, as well as thrombocytopenia and microangiopathic hemolytic anemia. So let's break this down and understand what's going on here, because these words don't really mean anything unless you understand what they're responsible for. What are Adam and Willie, as I'll call them, responsible for? So let's take a look here. We can see that the von Willebrand factor, the von Willebrand factor right here, is these little purple things hanging out in the vessel walls. So von Willebrand factor is a glycoprotein that's involved in hemostasis. It basically helps blood clot when needed. So we can take a look at Willie here. This is what he does. He basically makes the platelets stick to him, which is great when we need clotting. It's basically like sticky paper for platelets. They get stuck to it, they form clots. It's great in moderation, like I said, when you need clotting, but not so great if they get out of control and start this process all over the body. Obviously, this can cause a problem if this goes on too long. So Willie is very sticky. He likes all the platelets stuck to him, which is okay when we need it, but sometimes he gets a little bit out of control, and that's what Adam's here for. So what Adam does is when we get too much von Willebrand factor built up in the vessels, he basically snips them off and they kind of float off there, so we can see what happens there. And that just keeps things in control. Now, without Adam, Willie gets out of control, and we have all of these thrombi formed in the vessels, which leads to all of the problems we're going to see. So basically, all you need to know is that Adam keeps Willie in check, but in TTP, Adam's slacking. He's not around, he's in short supply, and now Willie can do whatever he wants. He's out of control, he's snatching up all the platelets, sticking them, causing all these thrombi in the vessel. So remember, TTP, all that's going on, there's not enough of Adam to keep Willie in check, and then we lead to these thrombi in the vessels and all the problems I'll go over in a minute. So that's what goes on in TTP. Not enough Adam to keep Willie in check. Now, what are the problems we're going to see with TTP? Well, there's a few different things you need to know. It's a pentad, and the way that you remember that pentad is by something known as fat RN. Apologize if there's any RNs watching this, no offense. This is just a great way to remember it. And, so it's called fat RN. That's the way you remember the clinical manifestations. So there's a pentad, and the pentad consists of fever, renal failure, fever, anemia, thrombocytopenia, renal failure, and neurologic changes. And obviously those letters, if you spell it out, spells fat RN. So that's the way you remember what symptoms you'll see or what clinical manifestations you'll see in TTP. So fever, anemia, specifically we're talking about microangiopathic hemolytic anemia, aka MAHA as they call it. It's a type of hemolytic anemia that results from those red blood cells passing through these vessels that are packed with microthrombi, like I showed you before, because Willie snatched them all up and it's just packed inside those vessels. Because of all that microthrombi, these red blood cells are bumping and banging up against things. Essentially, they're torn apart. So you'll see something known as schistocytes, which I'll go over on the diagnosis on the peripheral smear. And it's just these fragmented red blood cells. So if you see schistocytes on a smear, you know you're dealing with not just any anemia, but specifically microangiopathic hemolytic anemia. And basically, you just know that these red blood cells have had a bumpy ride through those vessels. It's not smooth sailing. Something's going on in the vessels when you see schistocytes. And then we have thrombocytopenia. Of course, this is low platelets. So you may see mucocutaneous bleeding, petechiae, purpura in these patients due to the low platelets. And the reason you have low platelets in TTP is because instead of your platelets floating around freely in the serum where we measure it, Willie snatched them all up. He's holding them hostage, and he's got them all stuck to himself inside those vessels. So that's why you have low platelets, because they're all stuck on that von Willebrand factor. And that's why we have low platelets or thrombocytopenia. Renal failure and neurologic changes. Most of the time, the renal failure is going to be just a decline in kidney function rather than failure. And the neurologic changes may be headache, confusion, stroke, seizure. These symptoms, the renal failure and the neurologic symptoms, they're because the clots are being formed, which we talked about before, and they're obstructing flow to the distal tissue. So the renal tissue, they're decreasing brain perfusion, and it leads to these neurologic sequelae, these neurologic symptoms that we see in the renal failure, potentially renal failure. So that's what you want to look for in clinical manifestations. It's fat RN, fever, anemia, thrombocytopenia, renal failure, and neurologic changes. Now, diagnosis is going to be made with low platelets, thrombocytopenia, normal coag panel, and schistocytes. So that's what we're looking for. So CBC, everything we're going to go over today has thrombocytopenia. So this isn't like a differentiating thing. Just know that they all have thrombocytopenia. That's why it's called the thrombocytopenia lecture. So CBC, low platelets. This is normally going to be severely low. So we're looking at a platelet count generally under 30,000. The coag panel, the PT, the PTT is going to be normal. We haven't activated our clotting cascade in these patients. They're not using up fibrinogen. None of their clotting factors are being used up. TTP is just a consequence of too much willy attracting too many platelets. So normal coag panel, and that helps us differentiate from DIC, which we'll go over shortly, which has the opposite, abnormal coag panel. Our D dimer is going to be negative. And then our smear, remember, we're going to see schistocytes. Remember schistocytes, microangiopathic hemolytic anemia. These red blood cells that had a bumpy ride, they're bumping up all over. All of those microthrombi, they're torn up, they're fragmented. And this is what they look like. It's basically just a schistocyte that's been like ripped in half. These just messed up, torn up red blood cells because they've had a bumpy ride in the vessels. It hasn't been like a nice smooth sailing for them. So that's what we know when we see schistocytes, something's going on in those vessels. And then also decreased ATOM TS13 levels. Obviously, we went over that before. You don't do this testing, though, to make the diagnosis on the spot. This testing can take up to a week. It can confirm the diagnosis, but it's never going to guide your treatment in a patient. It's something you do send out to confirm at a later time, but TTP is a medical emergency in a lot of cases, and it can be fatal. So if the appropriate treatment is not initiated promptly, these patients can die. So you don't wait for this to come back. It's just something you can do, and it may be in your vignette, but just know in real life, you may send this out to a lab, but you're not waiting for it to come back to treat the patient. Now, moving on to treatment, it's going to be something known as plasma exchange or plasmapheresis. So plasma exchange, it's the mainstay of treatment for TTP. All patients with TTP are going to be treated with plasma exchange until their platelet count normalizes. Remember, those platelet counts are really low. Prior to a time when we had plasma exchange therapy, the mortality rate for patients with TTP was close to 90%. So this therapy is crucial in treating these patients. If you're unfamiliar with plasma exchange, it's pretty simple. You basically take the bad plasma out from the person with TTP and you replace it with donor plasma. And what it does is it takes out the bad plasma with the autoantibodies that are restricting ATOM TS13, replaces it with new plasma that doesn't have these autoantibodies, so ATOM can do his thing. So next time you donate blood, donate some plasma too. You may save somebody's life with TTP. One thing that should be noted, when you're exchanging plasma, you might be thinking, well, they have severe thrombocytopenia. Why don't we do a transfusion of platelets? They have really low platelets. Why don't we give them just platelets and solve the problem? Well, you never do that. And the reason you don't do that, is you're feeding the beast, essentially. You're giving Willie some more platelets to hang on to and, his ability to create more clots. So giving platelets is a no-no. We don't feed the beast. You exchange the plasma, fix the problem. Don't help sticky Willie out and give him more platelets to hang on to. So that's why we don't give platelets in patients with TTP. An adjunct agent is also glucocorticoids, rituximab. Those are some other things that you may use for your severe patients. They generally improve the outcome in patients with TTP. They also decrease the required duration of plasma exchange. But overall, when you're looking for the answer in the vignette, be looking for plasma exchange. That's what they're going to ask you. Now, what do you need to know about TTP? You need to know that there's not enough ATOM around. Willie's getting out of control. Willie's hanging onto all those platelets, causing all the problems we see. And the problems that we're going to have is fat RN. So fever, anemia, thrombocytopenia, renal failure, neurologic changes. And then finally, how do we treat them? We treat them with plasma exchange. Give them some good plasma without all those problems with the decreased ATOM TS13 and all those antibodies against it. All right, let's move on to disseminated intravascular coagulation, DIC. So DIC is an acquired syndrome that leads to activation of the coagulation pathway, and it has the potential to cause both thrombosis and hemorrhage. So you may say to yourself, that makes no sense. These patients are developing thrombi, these clots, and plus they're bleeding, they're hemorrhaging at the same time. But what happens is, due to an underlying pathology, there's this inappropriate trigger. There's this activation of the clotting cascade. And these patients are forming clots all over the body in places where there's absolutely no need for a clot. And in doing so, they wind up consuming all of their clotting factors. So when they do need a clot, they have a blood draw performed or something, you need clotting to stop the bleeding. There's nothing left. It's been used all up unnecessarily in all these places. So they used up all their clotting factors and they just bleed and bleed and bleed, which leads us to the clinical manifestation we'll go over in a minute. Now, etiologies, all you need to know for etiologies is they are going to be sick, very sick. This isn't a patient that's walking around playing basketball, shopping at the grocery store, develops DIC. DIC is only going to occur in a patient with an underlying condition that leads to it. It's going to be a very sick patient. You're going to see patients with sepsis, malignancies, trauma, burns, heat stroke, amphetamine overdose. Doesn't matter. Just know in the vignette, this patient is not going to be doing well. That's what you look for in your DIC patient. If you think that's DIC in a vignette and they're healthy and they walked into the clinic, it's not DIC. So they have to be very, very sick for this to manifest. Now, clinical manifestations, the main thing you're looking for in the vignette is a sick patient, like I just went over, who is now bleeding. That's the key. Sick patient who's bleeding. Remember in the vignette, they're going to have a history of trauma, sepsis, malignancy, and they're absolutely going to be bleeding. And what you're looking for is this blood that's oozing from all over, from wound sites, catheters, drains, venipuncture sites, mucosal surfaces. They love to put this in the vignette, oozing from a venipuncture site or IV, oozing. So sick and bleeding, that's your clinical presentation. Also remember they're clotting, so they do have a bunch of clots in the body, so look out for thrombosis as well, so venous and arterial thrombosis. But in the vignette, the key, what they're going to put in there is going to be a sick and bleeding patient, and that's the key you're looking for. Now, diagnosis, this is going to be a little bit different, so listen up. So obviously on the CBC, we have thrombocytopenia, no surprise. Now, the key, though, is here. So actually, one more thing that's on the other one. So smear, schistocytes, yes, of course. You have microangiopathic hemolytic anemia because remember all the microthrombi and the thrombi throughout the body, shearing those red blood cells. So we have schistocytes as well. All right, here's the good part. Now, our PT and our PTT is increased. We didn't see this in TTP, so why? Why do we see an increased PT, PTT, and DIC? So, what does PT and PTT measure? It measures how long it takes to form a clot, your clotting time. What's going on in these patients? They're forming clots all over the damn place. They have very little clotting factors left, so it's obviously going to take them much longer to form a clot. They don't have the necessary ingredients, and therefore a patient with DIC, they're going to have an increased PT and PTT, increased clotting time because they've used all their factors up, and it's taken forever. Fibrinogen is going to be decreased, which is also unique here. It's being used to form those fibrin clots, so it's going to be low. And then finally, your D-dimer is going to be increased as well. We have all these fibrin clots all over the body. D-dimer is a fibrin degradation product, so it makes sense it would be elevated. Look at this, look at the red, because this is key. This is unique to DIC, and this is what you need to remember for it, is that those coagulation panel tests, those are going to be abnormal. Treatment. It's not much to know here. It's mainly fixing whatever's causing the DIC. So you fix the underlying disease, fix the underlying condition. So if they're septic, malignancy, burn, trauma, whatever it is, fix it to fix the DIC. And then supportive. So replace whatever they're low on. Hemoglobin, give them hemoglobin, platelets, etc. Unlike TTP, where we didn't give them platelets because it fed the beast, here we can, and you should. So there's no first line treatment here. Just fix the underlying disease, replace whatever's low. Pretty simple for DIC. Now, how do you remember the things you need to know in DIC? The way that I used to remember this is I threw on an extra D there, and I remember DDIC. I remember D stands for D-dimer, because remember, DIC is the only one you're going to see an elevated D-dimer, as well as your other coag factors, your PT, your PTT. So as soon as you see D-dimer, remember, okay, this is the only one that has the elevated D-dimer, as well as my PT, PTT being elevated. The other D stands for dripping. Remember, they're going to be dripping, oozing from venipuncture sites, catheters, drains, etc. Remember, they're dripping all over the place. Then I stands for ill. Remember, they're going to be sick, sepsis, trauma, malignancy. They're going to be ill. And then finally, clots. Remember, clots is what got us here. Those inappropriate clots, it's what got the patient into this mess. Widespread microthrombi, clots forming where they shouldn't be. They're using up all the clotting factors. That is DIC. Let's move on to hemolytic uremic syndrome. So this is a toxic mediated immune reaction. It's most commonly after a GI infection that leads to this triad. The triad is going to be microangiopathic hemolytic anemia, again, thrombocytopenia, and then acute kidney injury, which is somewhat unique here. We saw it in TTP as well, but it's more important for HUS. This isn't one of the triads that you're going to see where they say, well, this is a triad, and some patients will have one of the three. HUS it's the presence of all three. So you're not going to have a patient that just has anemia. It's all three to make that diagnosis of HUS. Now, you're generally going to see this in children, peak incidence in children younger than 5 years old. It can be seen in adults, but it's most common in children, and that's what you're going to see in the vignette. Look for a kid. Promise you it's not going to be an adult. If they give you HUS, they're going to give you a kid. Patho, so this is an endothelial injury due to exotoxin. So it's a byproduct of a Shiga toxin producing E. coli, specifically, and I underline this for a reason, enterohemorrhagic E. coli 0157.H7. This is important because this is the one that you're most likely going to see in here. The majority of the cases, I think around 90%, are caused from this organism. So it leads to microvascular thrombosis, results in microangiopathic hemolytic anemia, the triad again, thrombocytopenia, and acute kidney injury. So that's the triad from these exotoxins, specifically and most commonly the E. coli. So let's go into a little bit about what's going on here. So we have this infective organism that got into the body. A lot of times it's from ingestion of undercooked meat. So a lot of times they're going to mention a kid who ate a hamburger, and it wasn't cooked well enough, and the organism is ingested, and then it releases these exotoxins, and essentially it's wreaking havoc on the vascular endothelium. It has a predilection for the vascular bed of the kidneys, which is why we see renal problems in these patients. And then the damage to the vascular endothelium leads to microthrombi at the site of damage in the vessels. And then remember, we have this damage to the vascular endothelium. If you remember Virchow's triad in thrombosis, remember one of the three is endothelial injury. That's one of the components of the triad. And that's what happens in HUS, and that's why we have these clots. Now, before, remember, I mentioned E. coli 0157H7. Is this the only bacteria that can cause HUS? It's not. There's a number of other infective organisms, but like I said before, it's going to be the cause in about 90% of the cases in children in the US and Europe. So if you see HUS, that's the organism you're going to be looking for, that specific one. Clinical manifestations, you're looking for two things here. You're looking for GI and renal symptoms. Bloody diarrhea is a big one. They may also describe abdominal pain, vomiting. It's this prodromal illness that will likely precede the diagnosis of HUS by about 5 to 10 days. But diarrhea is the one you'll likely see in the vignette. Not always bloody, but a lot of times it is. So look for that diarrhea because that's probably going to be mentioned. And then some sort of renal manifestations. The level of severity can vary all the way up to an AKI requiring dialysis and acute kidney injury. But just remember, some sort of renal manifestation will likely be listed in the vignette: hematuria, proteinuria, oliguria, something going on with the kidneys. So remember, diarrhea and then some kind of renal manifestation you're going to see in the clinical manifestations. Diagnosis. So diagnosis, surprise, surprise, thrombocytopenia again. We're going to have low platelets. We're going to have a normal coag panel. So our PT, PTT are normal. Remember, the only one we're going over today that has an abnormal coag panel is DIC. So remember that. Everything else is going to have a normal coag panel. Of course, our D dimers are going to be negative. And then our smear, we're going to see schistocytes because remember, we have all of those thrombi. So that's going to tear up those red blood cells. So we're going to see schistocytes. And then the key here is elevated serum creatinine. So these labs are very similar to TTP, but the elevated serum creatinine is really the only thing that's very different. It could be in TTP. You may see a slight elevation in TTP, but not as common as in HUS and certainly not as high. So when you look at the vignette and they show you the labs, look for that severely elevated creatinine. You'll see that on the vignette as well when we're talking about HUS. Now, treatment's pretty simple. It's mainly just supportive. The management of HUS is primarily supportive. That's because there's no proven safe or beneficial therapeutic intervention. So it's IV fluids, dialysis, red blood cell transfusion. You take care of whatever they need at that time. The key you need to know about treatment is that you're going to avoid antibiotics and anti-motility agents, which is kind of weird because we're talking about an infection. Why wouldn't we use antibiotics? So E. coli infection, no antibiotics. It's odd. It doesn't make sense. But if you give these patients antibiotics, the antibiotics actually disrupt the bacterial membrane of the E. coli organisms, and it actually causes it to dump out more exotoxins, which makes it worse. So no antibiotics in these patients. It doesn't help. And most of the time it's going to make it worse. And the reason we don't use anti-motility agents, it's pretty simple. Anti-motility agents slow down the GI tract, and it basically just leads to the E. coli hanging out there longer than we'd like it to. So there's no benefit there either. So we don't want to expose the gut to those toxins any longer than we have to. So remember, no antibiotics, no antimotility agents, supportive therapy. And then before I go into the way I remembered this, I just want to mention again, I talked about it before, but whenever I had a question of HUS in school, whatever, I'd always mentioned a little kid who ate a hamburger. Clearly it wasn't cooked well enough. He ingested E. coli. Can come from other things too, you know, cheese, poultry, vegetables. But the question I always got was a kid who ate a hamburger that wasn't cooked well enough and they developed diarrhea, blah, blah, blah. So I mentioned that because this is part of my mnemonic and it only makes sense if I mention that first. So the way that I remember that, tack on an S to the end, and I remember hamburger, urinary symptoms, shitting, and school age. Apologize, I know this is a family show, but that was the only word that really makes sense here. So hamburger, like I mentioned before, undercooked, they ingested E. coli, and that's likely going to be in the vignette. It helps you remember E. coli is involved, that E. coli 0157. So you remember hamburger, undercooked, and that's what exposed them to E. coli. And then urinary symptoms. Remember, this involves the kidneys, so hematuria, oliguria, whatever it is, they're going to mention some urinary complaint. And then shitting. Sorry, again, no other word that works here. It doesn't work otherwise. So remember the vignette, they're going to mention they have GI complaints, likely bloody diarrhea. So remember that. And then finally, like I said, this is common in children under 5. So remember school age. Remember, it's going to be a young kid mentioned in this vignette. So remember HUSS, hamburger, urinary symptoms, shitting, and school age. I know this seems pretty simple, like it doesn't really tell you a lot, but when you're on an exam and you have all of these different things listed in the answer choices, DIC, TTP, ITP, you're going to be freaking out and not remember anything, and you can't remember which is which. If you just remember these few little simple things, hamburger, urinary symptoms, shitting, school age, it'll kind of get you there enough to you can remember, okay, this is the one with E. coli, this is the one with the diarrhea, blah, blah, blah. So little things like this will help. Hopefully they do for you. All right, so when we got a couple more, move on to immune thrombocytopenic purpura. So ITP used to be known as idiopathic thrombocytopenic purpura. Now it's known as immune. This is an acquired autoimmune hematologic disorder. It's characterized by isolated thrombocytopenia. So that's all you're going to see when we do the diagnosis, when we do our tests. It's more common in females. And then the patho, it's autoantibodies against the platelet membrane. It leads to splenic sequestration and phagocytosis. It's really simple. It's basically just the body turning against its own platelets and essentially destroying them. Most of the time we don't know why. That's why it used to be called idiopathic. There's essentially 2 main mechanisms or triggers that can lead to ITP. Infections, usually viral, and then some systemic conditions that alter the immune homeostasis. These are going to be your secondary causes of ITP, like HIV, hepatitis, lupus. On clinical manifestations, we're looking for really just one thing. A lot of patients are going to be asymptomatic, but if they do have symptoms, it's going to be symptoms related to thrombocytopenia. So you're looking for bleeding. Most of the time, it's going to be in the mucous membranes, like bleeding gums. They can also be in the skin, like petechiae and purpura. So that's what we're looking for. So bleeding, again, mucocutaneous is generally what they'll mention, like the epistasis, like the nosebleeds, bleeding gums. That's very common for them to mention in the vignettes. This is due to the low platelets, thrombocytopenia. This can occur in about 2/3 of patients. And then remember, of course, your petechiae, your purpura, your bleeding under the skin. Diagnosis, the only abnormal thing here is the platelets. So remember, you're going to have isolated thrombocytopenia. Everything else is normal. So your PT, your PTT is normal. We're not messing with the coagulation cascade here. Your D-dimer is going to be negative. And then the only one here that's going to have a normal smear, no schistocytes, is going to be your immune thrombocytic purpura. So red blood cells and leukocyte morphology is generally going to be normal in ITP. So why? Well, we saw schistocytes and everything else we've discussed so far. So why not an ITP? Well, remember, schistocytes are formed when red blood cells have that turbulent or bumpy ride in the vessels. And it was all caused in HUS, TTP, and DIC because of that thrombi. All of that thrombi in the vessels, for a number of different reasons, led to the schistocytes and that bumpy ride it had. In ITP, which does not have thrombi, it's only a condition of platelet destruction. We don't have schistocytes, and it makes sense because we're destroying platelets, but we're not doing anything to the vessels to give those red blood cells a bumpy ride. So remember, ITP, it does not have a lot of unique qualities. It's generally a diagnosis of exclusion. So this is really one of your few unique things about the condition, is that smear is generally going to be normal. Now, as far as treatment, 2 things that you need to know for treatment. and that's IVIG and steroids. And this depends on severity levels. Also be aware, especially in kids, a lot of times we're just going to observe. So if patients just have minor bleeding, mildly decreased platelet count, if it's like over 30,000, a lot of times we'll just observe, particularly in children. But otherwise, if they ask you for a medication, there's two ones, like I said, IV. You're looking for IVIG and steroids. So first, your glucocorticoids. Remember, this is an autoimmune process. In virtually all autoimmune conditions, steroids are our first line, and ITP is no different. So if the if the patient has really severe bleeding, they're really sick, then you have the option of giving them IVIG, which is intravenous immunoglobulin. So what this is, it's made up of healthy pooled immunoglobulins, IgG, from the plasma of blood donors. So you pump these patients full of healthy immunoglobulins, and essentially it gives their platelets a fighting chance at survival. You usually reserve IVIG for patients with severe bleeding, where you need to raise the platelet count. It really comes down to how bad is the bleeding and how fast we need to raise the platelet count, because IVIG will raise the platelet count in about 1 to 3 days. Glucocorticoids can take anywhere from 2 to 14 days. So steroids are usually first, but if they're severely bleeding, then you tack on IVIG. That's really it for treatment, outside of the fact that if they're refractory, you can do a splenectomy. Now, what do you need to know for immune thrombocytopenic purpura? So you need to know these are autobodies against platelets. We're attacking, we're killing the platelets. We're not doing anything else. We're not forming clots. Nothing else is going on here. There's a female predominance. There is isolated thrombocytopenia. So no schistocytes, normal coag panel. It's just going to be your thrombocytopenia that we see in these patients. And then finally, for treatment, we're doing steroids and IVIG for treatment. Otherwise, it can be observation if it's not too severe. That's really your need to know for your ITP. All right, let's move on to heparin-induced thrombocytopenia, and then we will wrap it up. I believe this is the last one. I hope for your sake it is. So heparin-induced thrombocytopenia, HIT. This is a life-threatening immune-mediated adverse drug reaction. It's caused by the emergence of antibodies that activate platelets from somebody exposed to heparin, somebody receiving heparin. This reaction leads to thrombocytopenia and thrombosis due to activation and consumption of platelets. So let's explain what's going on here. So we have thrombosis because this antibody is activating and churning out platelets. So we have all these platelets coming out, but ultimately we wind up with thrombocytopenia, so low platelets, because these platelets eventually, like in the other conditions we saw, aggregate or clump together, forming these clots. They get all used up, and then rather than floating around in the serum, they're stuck in those clumps. So we wind up with low platelets in the serum. Now remember, of course, we have a patient that's going to have heparin exposure in the last 5 to 10 days. That's what you're looking for in the vignette, someone who had heparin in the last week or so. That's the key, obviously. The patient was given heparin, and now they're throwing all these clots all over the place, and their platelets are drastically dropping. So it's pretty easy to figure this one out in a vignette. Remember, because sometimes we look for heparin mentioned in the vignette, and then we see something that says like enoxaparin or dalteparin. So remember the names of your low weight molecular heparins in case they don't flat out say heparin. So again, remember enoxaparin, dalteparin, those are your low molecular weight heparins. So remember, if you see those and you're like, wait, I don't see heparin, remember those are your low molecular weight heparins. And the way that I used to remember that is heparin, P-A-R-I-N, it ends in P-A-R-I-N, all of those do too. Enoxaparin, dalteparin, heparin, or heparin, I'm saying it wrong, but remember, so they all end in those last few letters, so you'll know this is a heparin type of medication, or a low molecular weight heparin. Okay, clinical manifestations. The main thing that we're looking for here is thrombosis and thrombotic sequelae. So let's take a look here what patients with HIT can develop. So it's pretty nasty. They're going to be clotting, so they're going to have venous and arterial thrombosis, sequelae like necrosis we see here, limb gangrene, organ infarction, pulmonary emboli. That's the main thing we're looking for in the vignette. Now, what about bleeding? We mentioned thrombocytopenia, so why not bleeding? All of the other conditions we focused on, bleeding was present, but despite the thrombocytopenia in these patients, it's actually pretty rare to see bleeding in HIT, so really you should just be focusing on thrombosis for your vignette. Now, diagnosis is going to be made with a combination of clinical and laboratory findings. So start off with your CBC, of course, thrombocytopenia, but the thing here is that the thrombocytopenia, it's going to be unique because in the vignette they're going to mention that this patient was admitted, blah, blah, blah. Their platelet count was however much normal number, insert here, 250,000 platelets. And then they were given heparin, and then 4 days later, their platelet count dropped to like 30,000. That's what they're going to mention. It's this 50% drop in platelet counts a few days after they started heparin. That's what we're looking for here. So of course, thrombocytopenia and everything, like in everything else, but remember that big drop, that 50% drop in platelet after heparin was initiated. You can also do your HIT antibodies. That's going to be positive. And then your PT and your PTT will usually be normal, surprisingly. Remember, this is a platelet activation problem. It's not a coagulation cascade problem, and they won't produce the consumptive coagulopathy we see in DIC with the elevated PTT, and the D-dimer. There's something else known. I'll just mention it. Definitely don't think you should memorize it, but there's something known as the 4T's probability scale. You'll use this in a real clinical setting. It's also known as the War-Kenton probability scale. It uses this grading system based on the severity of the thrombocytopenia, presence of thrombosis, etc. Do not memorize it for your exam. I just want you to know that that is something that exists, a scale that you might see used in the ER or other settings, but you do not need to know it for your exam. Just a heads up about the tools we use for diagnosis, for instance, the HIT antibodies. You don't ever wait for those to come back. If you suspect HIT, just like in TTP, with the right clinical presentation, you act fast. These patients can absolutely die. You have to act quickly. So these diagnostic tests, again, are great to confirm later on, like the HIT antibodies, but you can't wait in these patients. You have to treat them based on the clinical presentation, confirmed later with these tests. So treatment, what are we going to do for treatment? Well, obviously you want to stop the heparin. That's, pretty common sense here. But then you want to start a non-heparin anticoagulant, because remember, they're still full of clots. You need to anticoagulate. It just can't be with heparin anymore. So we need an alternative, and that alternative is generally going to be one of our non-heparin anticoagulants. And the most commonly used ones are your direct thrombin inhibitors. Argatroban is really a big one. That's the one, if you're going to remember one, you don't want to remember more than that, just remember Argatroban. That's the big one. Your direct thrombin inhibitors. There's a few other ones. You also have some direct oral anticoagulants, your apixaban, rivaroxaban, but just remember, if you're going to remember one, let's focus on this one here, because that's likely the one they'll ask you to switch to. Just remember, when you're looking in the answer choices, just make sure you're not picking something that's heparin, and you'll probably be right. They're not going to list this and then this, because it's hard to say which is better. They'll likely just list this along with maybe some of those other heparin agents that I told you about that have those trickier names. So this is what you're looking to switch them to, because remember, they still have those clots. We need to clear that up. Or we need to prevent the formation of new clots, which is what we do with anticoagulation. Now, what do you need to know? You need to know this patient will obviously have heparin exposure in the last 5 to 10 days. You need to know that they're going to have both the presence of thrombocytopenia, that big drop in the platelet counts, remember that significant drop after starting heparin, as well as thrombosis and all those thrombotic sequelae that we went over. And then finally, remember, treatment is going to be stop heparin, start a non-heparin agent. Remember, argatroban was going to be the big one if you're going to remember one. All right, now what I wanted to do for the last thing is I just wanted to kind of throw everything up here so we can look at everything side by side, because they all have different unique things, and I just want us to look at that again, because this can be a little complicated. They all are just so similar. So let's look at what's unique about all of them. So TTP, remember, we have our Adam TS13 deficiency. Adam's not keeping Willie in control. We have our fat RN for our clinical manifestations, and then remember, for treatment, we're focusing on plasmapheresis. HUS, remember, bloody diarrhea, and our AKI, remember, our acute kidney injury plus the bloody diarrhea, that prodromal GI infection. E. coli 0157H7 is the infective organism we'll most commonly see in these patients, predominantly seen in children. And then remember, treatment's going to be supportive, but avoid your antibiotics and your antimotility agents. HIT, remember, recent heparin exposure, thrombosis, all of that nasty stuff, your DVTs, your necrosis. Stop heparin, start a non-heparin agent. ITP, autoantibodies against platelets, isolated thrombocytopenia, no schistocytes, and then treatment, remember, steroids, IVIG if they need a little bit more, really crashing faster, platelets are dropping. And then finally, DIC, remember, this is going to be a sick patient. They're going to be septic, malignancy, etc. They're going to have an abnormal coag panel. This is the only one that's going to have that elevated PT, PTT, and your elevated D-dimer. And then remember, of course, for DIC, you're going to treat the underlying cause, malignancy, sepsis, whatever it is, to fix the patient and replace whatever they need. All right, that's everything up on the board there for you to remember the unique things about it. Let's do 5 quick questions and see what you remember. So list the pentad of clinical manifestations that can potentially be seen in a patient with thrombotic, thrombocytopenic purpura. So remember, that is going to be our fat RN, our fever, anemia, thrombocytopenia, renal failure, neurologic symptoms, fat RN. Question 2, a 57-year-old man who is in the ICU being treated for sepsis begins to develop excessive bleeding from his Foley catheter and IV site. Labs are drawn which show increased PT, PTT, increased D-dimer, as well as a peripheral smear that displays schistocytes. What diagnosis should be suspected in this patient? Remember, that is going to be disseminated intravascular coagulation. Remember, this patient is dripping, they are ill, they are clotting, and that is what we see here. This patient has dripping from the IV sites, the Foley catheter. The labs are drawn to show that increased PT, PTT. The D also, the D dimer is increased. And remember, this is a sick patient we mentioned. They're in the ICU being treated for sepsis. Question 3, a 47-year-old woman presents to the emergency department with severe mucocutaneous bleeding and labs which display isolated thrombocytopenia. Platelet count is very low, less than 30,000. She's later diagnosed with immune thrombocytopenic purpura, and she is started on glucocorticoids. What additional treatment should be added in this patient due to her severity level? Remember, we are going to add intravenous immunoglobulin IVIG in patients with ITP who have that severe bleeding or really low platelet count, in addition to the steroids. Question 4, clinical manifestations seen in thrombotic thrombocytopenic purpura are due to increased numbers of von Willebrand factor leading to platelet adhesion and causing small vessel thrombosis. The increased numbers of von Willebrand factor are due to a deficiency in which enzyme? So remember, that is going to be Adam. So Adam TS13. There's not enough of him around to keep Willie in check. Question 5, a 66-year-old woman receiving thromboprophylaxis with low molecular weight heparin 6 days post-op developed shortness of breath. It is discovered on CT that she has developed a pulmonary embolism. Labs show a platelet count of only 60,000, which is a significant decrease from her platelet count of 275,000 on admission. What treatment should be initiated in this patient for the likely diagnosis? So this patient clearly has heparin-induced thrombocytopenia. We're going to stop the heparin, start a non-heparin agent like argatroban. All right, so that is your thrombocytopenias. I know that can be a little bit confusing. I try to do the best I could to make it a little bit more simple, and hopefully that helped you. So please let me know in the comments if it did. And I thank you guys so much, as always, for all of the support. I really do appreciate it. So thank you so much. Good luck on your PANCE, your PANRE, your EORs, and good luck in PA school.